what prompted the workup is her mother, about 2 weeks postpartum, developed a DVT. And one of her sisters, while she was pregnant, also developed pulmonary embolism. And when she met her primary care doctor, they recommended to do this workup.
Got it. So I would also want to assess to see whether she's heterozygote for factor V Leiden or whether she's homozygote for factor V Leiden. I would also want to see whether she had any additional inherited thrombophilia testing aside from factor V Leiden as well.
I see. So tell me, you said this word homozygous, heterozygous. Elaborate more for me, please.
In terms of what the difference is between them two?
I don't understand what that means.
So I would want to know whether she carries 2 abnormal genes for factor V Leiden or 1 abnormal gene. My understanding is just based off family history alone that we could consider starting her on anticoagulant.
The patient stops you here and she goes, okay, what are the risks of my child having this factor V Leiden? And does it differ if I am homozygous or heterozygous?
So I would tell her that the risk does differ depending on whether she carries 1 abnormal copy or 2 abnormal copies of the gene.
How does that change? Her risk of an offspring, how does that change?
So if she was homozygous for factor V Leiden, she would pass, it would be 100% that her child is at least heterozygous for factor V Leiden. And if she was heterozygote for factor V Leiden, then I believe there would be a 50% chance that her child would obtain the mutation.
I see. So then let's assume, right, because you didn't ask me what was the result. Let's assume that this patient is homozygous for the gene in question here, and she has not had any personal history of a VTE other than the history of her close relatives that we talked about. What would be your management?
So if she was homozygous for factor V Leiden, I would recommend prophylactic anticoagulation throughout the pregnancy. I would also talk to her about some other risk mitigating behavior to decrease her risk of VTE in the pregnancy, such as avoiding prolonged car rides. I'm trying to make sure that she stayed active throughout the day and avoided prolonged immobility. And so that's how I would manage her.
I see. So you said you would put her on what medicine? I'm sorry, I may have missed that.
I didn't say the name of the medicine. I said prophylactic anticoagulation. I would talk to her about Lovenox or unfractionated heparin.
What do you do, doctor?
In my practice, I generally start people on 40 milligrams of Lovenox daily for prophylaxis.
I see. And do you continue that throughout the pregnancy, postpartum, for a year after delivery? What do you do?
So I generally start them on 40 milligrams throughout the pregnancy, and then I continue them on prophylaxis for 6 weeks postpartum.
I see. Now, is there anything additional steps that you would take during the pregnancy?
Yeah, so I would alter her dosing around the time of delivery. So generally, if this patient is going to have an induction of labor, I do tell her to hold her Lovenox 24 hours prior to the induction, or kind of PRN if she has any labor symptoms, and talk to her about the implications of why why I recommend that in terms of getting epidural and bleeding risks, etc.
So you said if she was coming in for an induction, what about if she was coming in for a scheduled cesarean?
So if she's coming in for a scheduled cesarean, I would tell her to I know that there is some guidance that if she's on prophylactic dosing, she can hold it for 12 hours before, but the anesthesiologists at our institution generally want them to be held for 24 hours. So I instruct her to hold it for 24 hours.
So there's no difference if she was coming for an induction or for a C-section. Is that what you're saying?
With respect to the Lovenox, that's my understanding.
I see. And when would you resume it postpartum?
So I would resume it 6 hours after delivery if she had a vaginal delivery, and then 12 hours after delivery if she had a cesarean section.
I see. Are there any instances where you would hold it longer?
I would hold it longer if she was at an elevated risk for continued bleeding postoperatively. Yeah, so that would be my main consideration for holding it longer.
Okay, so then you said your institution, your anesthesia doctors want you to hold it for 24 hours. Is that correct?
Correct, for prophylactic.
Are they comfortable with that? Preface it to actually put regional?
I'm sorry.
Are they comfortable putting regional anesthesia, such as a spinal and epidural, when they've stopped it for 24 hours?
Yes.
So I guess the question is then, how do they know it's safe? How do they monitor that the patient's not at an increased risk of bleeding? Don't you think it would be a better idea to have switched them to heparin?
To unfract, yeah. So I know that is also an option to switch them to unfractionated heparin, but that's not something that we routinely do in our institution.
Correct, but then how do the anesthesia doctors know it's safe to give a regional anesthesia? Because as far as I know, the Lovenox does not have a parameter for monitoring, such as a PT or a PTT or an INR.
Yeah, I would have to look that up.
Right, time. How did you think you did?
I thought I did okay, and then I got kind of nervous at the end in terms of I know that you can hold it, but I don't know exactly why they feel comfortable doing it.
So here's the deal. You did extremely well, right? You did extremely well. And that's what the examiners sometimes do. They mess with you. It's not my job to decide how long, whether I can give regional or not after Lovenox, right? It's not.
Yeah.
It's the anesthesia's job, right? And the reason why they do 24 hours in your institution is because you give the dosing of Lovenox every 24 hours. So they assume it's out of your system. But the reality of it is there is not a good way of monitoring the parameters for the PT and PTT and INR, right? It's not like you can't. But they have deemed the risk to be so low when you've stopped it for 24 hours that they still give it, they're comfortable with it, because it's very unlikely that you will have a clotting problem with that, all right? And that's why your institution does it. But the only reason I went to that is, I kid you not, you did so well that I'm like, all right, what else can I ask you, right? You nailed the homozygous, heterozygous. You told me you were going to put them on prophylactic dose. You're going to continue them for 6 hours. You're going to hold it for labor. You're going to resume it afterwards, which is the common things that I, and you even asked me, and I was intentionally just put factor V light, and you asked me if there was any other thrombophilias. You asked me why she got tested. You asked me about all of that. You said you're going to take a history. You're going to, the other thing. I mean, maybe if I'm going to be very critical, I would just say, and I will also counsel the patient that even though she's on prophylactic, anticoagulation, that does not prevent all clots. So I will counsel her on all the signs and symptoms of PE and VTE and instruct her to come to the hospital if she develops any, right? But I'm just being critical. You would have passed, no questions. Nothing that you did here was out of the ordinary. It was superb management, and I really, truly, at the end of it, was like, I don't know what to ask you anymore. Let's play with anesthesia, right?
I appreciate that. I do have one quick question.
Mm-hmm.
I would have said I had to look it up because I don't remember off the top of my head. But if you had told me she was a heterozygote and you gave the family history of multiple prior members have had a VTE, is it just you can consider anticoagulation, or do you anticoagulate?
I did even better for you. Look at that.
I knew it was somewhere in the chart, but I couldn't remember it off the top of my head.
So there you go. I have the chart for you, right? So what was your scenario?
Basically the one that you had presented about multiple prior family members, but if you had told me she was a heterozygote and not a homozygote.
So low-risk thrombophobia with a family history. There it is. You could do surveillance, but I'm going to tell you, I'd be very reluctant. I would give them anticoagulation, and then they don't give you the option postpartum.
Got it. Okay.
Okay, so that's where that is. Okay.
Perfect. Thank you.
Okay, but in general, if you notice something, even with high risk thrombophilias, right? High risk thrombophilia with a single, high risk 2 more episodes, you're never wrong, right? Most of the time, right? If you go with intermediate.
Mm-hmm.
See? And that's one way of studying. Which one in the table is the one that actually keeps coming the most? Intermediate, 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 right? So then if you know that all of these are intermediate, and then if you have more than 2 episodes, you become adjusted, right? And then the other ones are all prophylactic unless you don't have, unless you don't have a history of a VTE and you're a low thrombophilia, see how I'm saying? That's one way that I would do it. Because what is the wrong thing to do in the exam? To say you can either give prophylactic or intermediate. Is that a correct way to answer a question? No. Because they want to know what
you would do.
Exactly. All right. And those of you that want to know the difference between prophylactic and intermediate and adjusted, I've put that there for you as well. Okay. And then the holding, is it 12 hours, 24 hours, and so forth, is also there for you. Okay. So technically your hospital's not doing it 100% like ACOG does, but that's fine. That's what your anesthesia doctors and what you want to do based on what your anesthesia doctors, and you can't argue with them, right?
Mm-hmm.
Okay, so that's fine, fair enough. All right, let's see who is next. All right, thank you very much. Well done, good job.
Appreciate it, thank you.
Okay. All right, let's see who is next on our list. All right. If you are next on the list, Dr. Hall, are you on there? Please raise your hand. I don't see Dr. Hall. Let's go down the list. Dr. Freeman. It's a very long list for me to go through. So if you see your name, raise your hand. All right. Okay. Anybody see their name? Dr. Du, right? I think. Anybody before Dr. Du that's on the list? Dr. Foster. All right, there you go. Let's go with Dr. Foster. Okay. Are you ready for us? Let me unmute you, Dr. Foster. You ready for the challenge that lays ahead?
Hello, can you hear me?
Yes. Are you ready for the challenge? Okay.
I am ready.
And you guys probably know by now I'm a little bit tough, but trust me, that's how the examiners are. Okay.
Okay.
All right. Let's go. So, a 27-year-old G1 P0 presents to labor and delivery at 30 weeks of gestation. Her blood pressure is 170 over 115. How are you going to manage this patient?
First,
and it's a vague scenario. I understand that, but that's intentional.
Okay. First, I will get a detailed history and physical, just to inquire about her status of blood pressure, like if she has a history of chronic hypertension or gestational hypertension or any other hypertensive disorders in pregnancy. I would ask her questions about symptoms. If she has any headaches, go to MATA, write up a quadrant pain or visual changes. And then I would put her on the monitor, like for fetal heart rate tracing. And I would start to check her blood pressures Q15 minutes.
I see. So you don't think that putting an IV access here and doing labs is part of what you would do?
Yes, I would do that as well. I would assess while we're waiting. So I would assess her blood pressures starting and send labs while we're waiting as well.
I see. So let's assume that you repeat the blood pressure in 15 minutes and it is a similar blood pressure, let's say above 160 over 110. The number doesn't really matter.
Mhm.
What are you going to do?
So given that it's been sustained for over 15 minutes, I would have inquired to see if she had chronic hypertension, to see if
I'm
she
sorry, doctor, you
had,
keep saying chronic, you keep saying she has chronic hypertension. So how would that differ in your management of a severe range blood pressure?
well, at that time, I would inquire just to see if she had taken her daily medications for that day. So that would kind of
So,
help.
doctor,
But
would you not treat a severe range blood pressure if she was chronic hypertensive on medications?
I would treat her severe range blood pressures, but I would also considering if she had missed her dose after treating her severe range, restarting her on her home medication as well. So that's why I would want to know if she had chronic hypertension. But if she presented, yes, I would go ahead and treat her, but I would want to know what home medication she's on and if she had missed her dose, so for my later management. So if her blood pressure had persisted,
She's not chronic hypertensive, this lady.
okay. If her blood pressures had persisted and were elevated, I would inquire about, I would check her heart rate, make sure that it's not, she's not bradycardic. If she's not bradycardic, I would start her on, give her initial dose of 20 milligrams IV of labetalol.
Why did you choose labetalol?
That in my pathway, that's one of the things that I can give in addition to others. And so if her heart rate was normal, if her heart rate, if she wasn't bradycardic, that would be one of the initial IV medications that I would give.
Okay, and then when would you instruct your nurse to repeat the blood pressure?
In 10 minutes.
And there are any other additional things that you would like to do at this point in time?
If I was treating her, I would go ahead and admit her to the hospital. I would start her on magnesium. I would, since she's 31 weeks, I would also give her betamethasone, 12 milligrams to be redosed at 24 hours.
And you said magnesium, correct?
Yeah, yes. Usually I would do a 6 milligram loading dose and with a 2 milligram maintenance.
Okay. So you said you were going to repeat the blood pressure in 10 minutes. Is that correct?
Yes.
So that blood pressure now comes back at 180 over 111.
Okay. Then I would give her another dose of labetalol, pending that her heart rate is still in the normal range. I would give her 40 of labetalol.
I see. Okay. Let's assume, and when are you going to repeat the blood pressure again?
Again in 10 minutes.
Now her blood pressure comes back in 10 minutes and it's again 180 over 115. What are you going to do at that point in time?
I would check, make sure that like all of our tools are the cuff is in the proper place, that the blood pressure is accurate. If it is accurate, then I would proceed and give her a dose of labetalol 80.
Okay. If labetalol does not work, what alternative medicine do you think you can give her?
I could switch over to hydralazine and give hydralazine 5 milligrams.
What is your 5 milligrams as your initial dose?
10 milligrams. Did I say 5? 10 milligrams. If I'm switching over from labetalol.
Okay. And
at that time, if I'm switching to hydralazine, giving that higher dose, I will also be like consulting MFN. as well.
I see. And what do you anticipate MFM to add to you at this point in time?
I would be consulting him mainly because after I got to that high of a dose, I would be concerned that if that doesn't control it, that I might have to admit her to the ICU for a drip. And I would need assistance with maintaining that or managing it.
I see. So let's assume when you gave the order to give the IV labetalol, your nurse came back and told you that she was a very hard stick, that you are unable to obtain IV access. Would you consider it a different medicine at this point in time? Assuming that you had given none of the previous medicines.
I would consider giving Procardia 10 milligrams, immediate release, PO.
Okay. Let's say if your management of your initial labetalol was successful and it lowered the blood pressure out of the blood pressure out of the severe range, right? Would you consider putting this patient on a longer acting antihypertensive at this point in time?
Not immediately. I would see if she stabilizes on her own, because I wouldn't want to bring her down too low given the risk to the fetus and placental.
And Doctor, what makes you think, Doctor, that somebody who came in with severe blood pressures in the severe range will make her normalize? Aren't those medicines you're giving short acting?
They are short acting, but I'm not saying that she would be normal, but my intention is not to make her normal. It's to bring them out of the severe range. And I also don't want to bring her down too low. So I'm not saying I wouldn't start her on a maintenance medication, but I wouldn't do it immediately. I would kind of monitor first to see where she stabilizes. If she stabilizes on the higher end, I would initiate like a long-acting medication, but I wouldn't do it immediately.
I see. Right. Time. How do you think you did? Oh, first of all, how bad was I?
You weren't bad. I mean, it's what I expect. My hands are sweating.
Again, you guys are you nailed it. You did very well, right? And I was being very jerky in everything that I asked you and whatever, but you stick to your guns. I agree with you totally. I wouldn't start this patient on anything long-acting till I get more information, correct?
Okay.
Right? You're right. I got you out of the severe. What am I going to do? Cycle your blood pressures multiple times to see what it does in the next couple of hours. You're on magnesium. You're on labor and delivery. I'm monitoring your blood pressure. You're not going anywhere, right? And I'm trying to make decisions as you await the labs, right? Because more information is going to give you more guidance, correct?
Yeah.
What do you think you could have done better, though? Because I could have made your life a little bit more difficult, because you went and you said, I'm going to take a history and physical and talk to the patient bedside, right? But is that truly what you do? Or do you have other people and members of the team also work to do things at the same time? So imagine you going to whatever triage, OB triage, and somebody says that I've got severe range blood pressures, right? What are you going to tell your nurse to do as you're walking there?
Oh yeah, like it's all happening simultaneously. I mean, I'm taking the history, but they're cycling her blood pressures, they're getting IV access, they're sending labs. So I would,
Correct.
Okay,
you answered everything correctly, but a more elegant answer that tells them, hey, I'm not just concentrating on the patient's history. I'm actually know this is an emergency, and I'm going to get things going from multiple areas, right? And that's why I really don't think you need an IV access. Oh, sure I do. What of course I'm going to get an IV access, right? But remember, if you didn't say it, then they're going to assume it wasn't done, right? Now, this is not necessarily the only way to answer, but this is one of the answers to say, Management of severe range blood pressure is considered an acceptable emergency and requires collaboration and coordination between team members where multiple different things are being done simultaneously, right?
Okay. Mhm.
That's a good segue into it. And then you can say, I will notify the charge nurse that we have a patient with severe blood pressures and start designating roles and making sure that adequate personnel are available. Look at that.
Okay.
That shows that you're on top of it, you're thinking this can need more people, more things, more resources, right? I mean, who doesn't get freaked out when you have a 180 coming through the door, right? She may have drugs, she may have unstable labs, she may have all of that sort of stuff. Now, the things that you did is history and physical, explain to the patient the situation, fetal heart tracing, preeclampsia labs, IV access, right? The blood pressure and still severe. You can give labetalol. I just picked labetalol because it's fine. And you don't have to say pulse, right? What can you say? What would be a better way of answering that question? I will give you all unless there is a contraindication.
Unless it's a contraindication.
Let
Okay.
them ask you, right?
Gotcha.
And you're assessing magnesium sulfate, which you did, inform anesthesia and NICU, give steroids when applicable, right? This is not coming from me. This is coming from ACOG's hypertensive emergency checklist. See it? So what you did was absolutely correct, right? And then your medicine use, none of it was incorrect at all. Okay?
Okay. Okay.
Perfect. Well done. Good job.
Thank you.
All right. All right. Who else is on our list? Did I miss anybody that is above Dr. Foster? Please raise your hand. If you are below Dr. Foster, please raise your hand now so that I can see. Emily, is that, do I see your name here? Did we spell it wrong or am I? No, I think it's not the same as. All right. Dr. Wang. All right, let's go. Did my unmute work?
I think so. Hi there.
Hello, how are you?
I'm doing fine. How are you?
I'm good. I'm glad you didn't run away, right? With all the difficult quizzing that I'm giving you guys.
Tempting.
But honestly, you guys are going to say, God, I'm glad he quizzed us that way because the exam will feel a lot more easier. Okay? All right. So a 29-year-old presents, a G1P0 presents for anatomic survey, and she is 21 weeks and 0 days. And the image below is obtained on a transvaginal ultrasound. Tell me what you see here.
So this is an OB ultrasound. Appears to be in the sagittal plane. I see the cervix, and then I see that there is a Doppler signal just adjacent to the cervix. So I'm thinking that this is indicating some sort of abnormal placentation.
Okay, so tell me what would be your differential.
For this patient, I would be thinking about things such as placenta previa, vasa previa, velamentous cord insertion.
I'm sorry, what's the difference between a vasa previa and a velamentous cord insertion?
For the vasa previa, the velamentous cord insertion is seen within 2 centimeters of the cervical os.
So then wouldn't a vasa previa be a subset or a velamentous or something like that? Or a specific type of velamentous? Okay,
yes.
What's your other differential?
Let's see
Just
here.
record.
So how do you know that this is not a maternal vessel?
That
Maybe
yes.
whoever did the ultrasound just went a little bit more lateral than they should.
I suppose that is a possibility.
So how would you differentiate?
I think I would say it's difficult to tell from a single still image. So
Correct. Even that it's not a still image and you're the one that was doing the scan, what would you be able to do to differentiate whether this is a fetal vessel or a maternal vessel?
one way that you could differentiate is to get a Doppler signal and look at the heart rate, and that should be able to help you decide.
I see. Okay, so you said this could be a vasa previa, correct?
Correct.
How do you know it's not a phonic presentation?
I think at this point, I don't know for sure. I think I would have to see where the placenta actually is. If it's, for example, a fundal placenta, then I think I would be more inclined to think that this is more likely a phonic presentation.
Okay, let's assume that you're fairly confident that this is a vasa previa. All right. Please tell me, how would you, what would you counsel the patient on? And what would be your typical management of such a presentation?
Sure. So for this patient, I would explain the ultrasound findings to her, namely that we have basically these fetal vessels that are essentially not optimally protected and they're traveling near the opening to the cervix. I would tell her that with this condition, it is very high risk for the pregnancy. Namely, there is a very high risk of bleeding, which would be dangerous to both her and her baby. So for this pregnancy, I would want to watch this patient very closely. Most likely, I would be managing this patient in conjunction with maternal fetal medicine. During the pregnancy, I would be obtaining serial growth ultrasounds to ensure that the fetus was on a normal growth trajectory. I would be counseling the patient constantly to alert us promptly or present for evaluation if she notices any signs of bleeding, as that warrants immediate evaluation. And then I would admit the patient at the beginning of the third trimester and deliver her by cesarean delivery, usually between 32 and 34 weeks.
I see. Anything else that you would consider?
I think those are the major things that come to mind right now.
Okay, so let's go back to, you said admit in the third trimester, correct?
Correct.
So if this was the patient and you were manager, can you please be more specific at the gestational age that you would admit?
I would admit this patient at 28 weeks.
I see. Are there any things that would make you admit her earlier?
Sure. So if the patient did have an episode of bleeding, or if the patient had severe fetal growth restriction, I think those are the two main things I would be looking for to prompt an earlier delivery for her.
Not delivery, I was saying admission.
Oh, sorry, earlier admission.
So what about patient's symptoms? Would that play a role? Contractions, maybe?
Yes, that would be very concerning as well in this patient.
Okay, so do you think that there is a role for utilization of serial cervical lengths and FFN? to dictate your timing of admission?
So I think that for there may be a role for the cervical length. Honestly, that is something that I would have to discuss in conjunction with maternal fetal medicine. As far as the fetal fibronectin, from my understanding, that's mostly useful in terms of its negative predictive value. So I'm trying to think about what situation that would.
Yeah, so as long as the fetal fibronectin is negative, you keep the patient out.
I think with how high risk this condition is, if she had contractions, I don't know that I would be reassured enough to, if she still had, symptoms of uterine contractions, I don't know that that would be enough to.
So doctor, let's go back to when you would deliver this patient, because I heard you say 32 to 34 weeks. Is that correct?
That is what I said.
Okay. Do you want to change your mind and maybe change the gestational age?
From what I can recall, just given the high risk nature of this condition, I do believe that we do a significantly preterm delivery for these patients.
Okay. So you said preterm delivery, correct?
Correct.
I did not hear you mention the word steroids at all.
Oh, I apologize. So when in preparation of a planned preterm delivery, you would give antenatal steroids.
At what gestational age would you give it?
For this patient, I would give it to her on admission to the hospital.
But if you deliver her at 28 weeks and deliver her at 32, wouldn't that evade the optimal steroid window?
It would. You do have an option of giving a rescue course of steroids if needed.
Time. How do you think you did?
Not awesome.
So I can tell you what I think. Okay, what prompted you second guessed yourself a lot, and I could sense that. Am I right?
Yeah, I don't manage this problem very often.
And guess what? You can be very upfront and say, usually when I'm faced with this problem, I manage this at the very beginning. You can say, I usually manage this in conjunction with maternal fetal medicine. They're not going to let you off the hook, but you're making it very clear that I don't manage this, right?
Mm-hmm.
And so I would start with this. Is this an easy diagnosis to make? No, right? But should anybody doing anatomic surveys look at the lower uterine segment, put color on it, and look for it? Absolutely, right? Did you give me the differential pretty good? Yes. And then when I prompted you to a fetal vessel versus you got that correct, right? So if you were faced with this as a structured case, I think you'll be put at that. You will probably pass based on the overall. So you actually didn't do horribly, and probably the other cases will carry you through. So you didn't do as horribly as you thought, because you got the general gist of it. And I could tell straight away when I said betamethasone that you had just simply forgotten because of the gravity of the situation, right? You did get the gestational age of delivery incorrect, though. Okay. Now remember, vasa previa is not just a velamentous cord insertion that is within 2 centimeters. It's also a succensurate lobe that has the connection covering the cervix. Don't forget that as well, right? I know I didn't ask you, but I just don't want you. So this is the general gist of it, okay? So management is antenatal steroids between 28 to 32 weeks. Consideration, for preterm hospitalization at 30 weeks, right? Delivery at 34 to 37 weeks. So what would be a good straight answer for this? You can say, I routinely admit my vasa previas at 30 weeks, right? And I give them steroids on admission. Perfect. With the knowledge that if more than 10 days have elapsed, I may repeat them as needed prior to 34 weeks. And I plan to deliver as close to 37 weeks as I possibly can. This management plan may be altered based on the patient's symptoms.
Got it.
See how that answer is like straight to the point? Why did I pick 30 weeks?
That's much better.
Why did I pick 30 weeks?
Because it falls in the right window for both.
So who cares? They don't want to. They don't want to between this. I normally admit them at 30 weeks. Thank you. That's my management. Can I change it? Yes. This plan may be altered by patient's symptoms, proximity to the hospital, whatever. Okay. Now, are there some people that utilize cervical lengths and fetal fibronectin? There are. There are people that bring these patients every 2 weeks, measure the cervical length, and do a fetal fibronectin prior to that. And as long as the cervical length is maintained, above a certain level, so most people use 2.5 and above, right? And the fetal fibronectin is negative, they may make them stay out of the hospital till closer to 34 weeks. You don't have to. I can tell you, we admit them at 34 weeks, give them steroids, keep them pregnant, deliver them somewhere around the 36-week mark. And that is an absolutely acceptable way of managing vasa previa. Now, how do you differentiate, which is what I asked you, phunic presentation from a vasa previa? Time will tell you, right? If you put the patient in T-Berg and it goes away, is that a vasa previa?
No.
No. If you put her in a T-Berg and it doesn't go away, you still haven't finalized the problem. But if you bring her back in a week and it's still there, is that a phunic presentation? No. If you follow the placenta and see a cord insertion that is right smack in the middle of the fundal placenta, is that a vasa previa? No, which you did get. All right. Is this your typical run-of-the-mill general? No. Is it outside of what a generalist should know and should know how to manage and stuff? The answer is also no. So it is a fair game question. All right. Was my summary of it helpful?
Definitely.
Okay, so you see where I'm going with this? You need to say the correct answer with the least amount of words in the most straightforward way, right? Be confident about it is how you go. What is your practice? Don't give me a range. I admit at this point, give steroids at this point, and deliver at this point, unless something in the clinical picture changes my mind. All right? Perfect. Well done. Well done. Don't worry. It's a tough case.
I have one question. So clearly I was not sure on the optimal gestational age for hospitalization and delivery. How should I navigate that on the exam?
I would say something along the lines of, okay, I do not recall the exact gestational age. If I'm faced with a situation like this, before I will look up and find out the most optimal age. However, if I recall correctly, it is.
Okay.
See how you've managed to go, I don't recall the exact, but I know it's, but I would look at, because what, is this truly an emergency?
Usually not. No.
Okay. And if it presents as an emergency, does anybody care about the gestational age?
Probably not.
No, because you're going to be bleeding and, all sorts of stuff. And actually, you're not even going to care what the diagnosis is. If you have vaginal bleeding with fetal bradycardia, it doesn't matter whether it's an abruption or a vasa previa or whatever. You got bleeding and bradycardia, you're going to run to the OR. So in this case, it's not considered an emergency. You can say, I don't recall the exact timing of delivery. However, faced with this situation, I will look up at the optimal timing of delivery, and then based on shared decision making, I will decide with the patient when to deliver. And if I recall, it's sometime in the, late preterm period. Perfect. Right? Which you got to the general vicinity, and that sounds relatively correct. Okay? But it's okay. As long as every time I put you in the hot seat, you're like, okay, I'm a step closer to being ready for this exam, then we've established what we need to establish, right?
Yeah.
All right, well done. Take care.
Thank you.
Okay, let's look at our list and see. Who do we have? If you see your name on the list, please raise your hand for me. There you go. Ravi, you ready for us? Okay. I'm going to unmute you. All right, Ravi, you ready?
Hello, yes.
Okay, perfect. So let's get your case, which is case number 4. Okay. So a 27-year-old G1P0 presents to labor and delivery. Okay, at 31 weeks of gestation, her blood pressure is 170 to 115 with a similar repeat in 50 minutes. 20 milligrams of labetalol is given, and her repeat now is 134/98. What is your management?
At this point, I would have gotten a detailed history with the patient to see if she had a history of chronic hypertension versus if this is a patient who has new onset high blood pressures. In the setting of new onset high blood pressures, given that we did treat her, I would recommend hospitalization for severe preeclampsia. And I would, at this point, also
How do you know she's preeclampsia with severe features?
given that she had a severe range blood pressure that we did treat, I would say that would rule her in for a diagnosis of severe preeclampsia, unless she had that history of chronic hypertension before.
So couldn't she just be gestational hypertension?
She could be gestational. However, given that we did treat a severe range blood pressure, the diagnosis is, I believe, formally known as preeclampsia with severe features because you did treat her.
I see. Okay, let's move on. What else would you want to do?
I would recommend betamethasone. I would give her for fetal lung maturity, as well as start her on magnesium to prevent any to decrease the chances of eclampsia, as well as to prepare us for delivery if it did become indicated. And I would wait for her preeclampsia labs to return.
Okay, so let's say her initial preeclampsia labs came back with a normal creatinine, normal LFTs, and normal platelets.
What was her P to C ratio as well?
Okay, so it was 0.7.
Okay. With that, with me treating her, I would recommend staying in the hospital, continuing to letting her continue remaining pregnant, and then keep her hospitalized with NSTs and in my practice, I would start her off on daily labs until we make sure they're stable.
Daily labs?
At this point, yes, while she's hospitalized.
I see. And what particularly are you interested in these daily labs that you're doing?
Worsening preeclampsia. So I'm looking for liver function, creatinine, or kidney disease, anything that would preclude us from letting her remain pregnant at this time.
I see. And are there any other things that you would like to do?
The NICU would have been consulted. I would have also gotten a growth ultrasound to evaluate for any evidence of IUGR as well. And I would have discussed with anesthesia to let them know about this patient and that she's hospitalized as well.
Okay. Are there any other parameters in the ultrasound that you may want to look at or consider in this scenario?
At this point, if she's only 31 weeks, I would check to see, positioning, fluid level. I could consider doing Doppler studies if her fetus is measuring small as well.
And if it's measuring normal, you don't think there's any utilization of Doppler studies in this scenario?
Not at this time, no.
Okay. So would you start her on any antihypertensive medications at this point in time?
I would have to see what her blood pressures were doing. If they If they remained less than severe range, I would not start her on any long-term antihypertensives.
Doctor, are you not aware of the CHAP trial that says that we have to start blood pressures control if they're consistently in the 140s or the 90s?
I am aware of that trial. I do apologize. I have to do a little bit more reading into that trial, but I thought that was mostly in relationship to chronic hypertension, not newly diagnosed gestational hypertensives.
I see. I see. Okay, so let's go back to your management again. What would be your goal gestational age of delivery if everything remains stable?
34 weeks and 0 days.
Would you consider outpatient management?
I would not consider outpatient management for this patient who has shown severe features of preeclampsia.
Will you continue the magnesium sulfate till 34 weeks?
No, I would continue it for 24 hours initially upon admission, and then once we had stabilized the patient, ensuring that our blood pressures were normalized, I would restart it when we moved towards delivery.
Okay, so can you please tell me what would be some of the things that would make you deliver this patient before 34 weeks?
Worsening kidney function, creatinine greater than 1.1, doubling of her AST, signs or symptoms of a headache that did not improve with medication.
Doubling of her ASD. So if they started out at 5, would you deliver her at 10?
Sorry, I apologize. I misspoke. I meant twice the upper limit of normal. Okay. For us, that our lab is, our normal is 33.
Don't volunteer. Don't volunteer numbers.
Okay.
You're doing good. Don't volunteer numbers.
Okay.
Unless I ask you specifically, don't volunteer.
Perfect.
Okay. Yeah. You are doing perfectly. Don't get yourself into, unless you want to bait the examiner, don't get them into a place unless you want to go there. Okay. You want to volunteer the numbers?
No, I do not.
All right, that's good. All right, go ahead. What else would make you do
an unrelenting headache with associated vision changes that was not improving with medical management. Signs are...
What made you move from lab to symptoms?
Oh, I apologize. I forgot one more lab value.
I'm just asking, this is really true. Like, this is not part of the exam. I'm just asking, what made you move from, like, why did you not go through, let me go through symptoms, then through lab? Like, you know what I'm saying is, organized line of,
I think,
and this is not maybe like, I'm not trying to be difficult. You just want to look elegant.
Yes, I think it was my nervousness that caught up with me.
Okay, so why are you nervous? Because you're doing very well. I
misinterpreted the CHAP trial, so I think that's still in my brain, and so I apologize that
No, you actually got it right. The CHAP trial is for chronic hypertension.
But in my head I had thought I had got it wrong, so I was perseverating on it.
Yeah. You actually did get it right. It's for chronic hypertension. Now, would you consider because your time is up anyhow? So would you consider starting the patient on antihypertensive? Yes, because if she continues to teeter close to the severe range blood pressure, what's my goal? To keep her the severe range blood pressure so that I can conservatively manage her till 34 weeks. So it is acceptable, right, to start them on antihypertensives because you've made the diagnosis of preeclampsia with severe features to try and bridge them to the 34-week. But if it was preeclampsia without severe features and she was constantly in the 140s, 150s, I wouldn't start them because I don't want that to mask preeclampsia with severe features. You see the difference?
Yes, sir.
All right. Now, what are some of the other contraindications to, now that we're stopped quick, what is something that you guys always forget as a contraindication to conservative management? You guys are really good at giving me the labs, the headache, the blurring of vision, but you guys forget something constantly.
Pulmonary edema or non-reassuring tracing?
Yes, so you've got to say, the first thing you've got to say, because why are we prolonging the pregnancy?
To improve fetal outcome.
Correct. So if the fetal outcome is already compromised with recurrent decelerations or non-reassuring status, then would you prolong the pregnancy?
No, I would not.
Okay. And if it's something, and this is what a lot of you also forget, what if it's a lethal anomaly?
Then I would not prolong the pregnancy.
Correct. So those are all contraindications to conservative management. Now, very interestingly, I've been doing a lot of, like, I do a lot of the oral, and I see that there's a lot of people that monitor creatinine above 1.1 and do serial creatinins or serial LFTs if they're double the normal. I can tell you, as MFMs in our hospital, our interpretation of the guidelines is once you hit double the normal of LFTs or creatinine above 1.1 or platelets less than 100,000, unless we're waiting to get to the steroid window in somebody who is extremely premature, that is an indication for us to deliver, right? And the reason why some people say, because here are the conditions precluding to expectant management. This is when you wouldn't do expectant management. Uncontrolled severe headache, persistent headaches, epigastric pain, visual disturbances, stroke, myocardial infarction, HELP syndrome. So people will say, oh, I'll monitor the LFTs because it's not HELP syndrome. But if your LFTs are double the normal or your platelets are less than 100,000, my interpretation is it doesn't have to be full HELP. It can be elevated. So I think I agree with the double twice normal should deliver unless you're bridging to pulmonary edema, eclampsia, suspected abruption, and then here, abnormal fetal testing, fetal demise, fetus with that does not have, has a lethal anomaly. Now this is an interesting one because it says persistent reversed end diastolic flow, correct?
Yes, that is what it says.
But then it also tells you not to do Doppler studies. So go figure.
Yeah.
All right. But I'm going to say this is probably the way it is because in the instance of fetal growth restriction plus reversal of flow, that means you should not keep the patient pregnant anymore. All right, perfect. Any questions for me?
How do you think I did other than my nerves?
Very well. Very well. Okay. I actually think all four of you, given the circumstances, have done extremely well. I don't think any of you have anything to worry about. And I kid you not, on the scale of tough examiners, this is a very tough examiner. Because I questioned everything that you said. I wasn't very nice. Unfortunately, I'm a nice guy, but not in today's session, right? But this is the type of session that you want, and you did very well, right? But you also have to do very well on what we call the bread and butter. So they'll give you more forgiveness in the vasa previa because it's not the bread and butter, right? So they're more likely to forgive vasa previa over preeclampsia. All right, perfect. Okay. Well done.
Thank you.
All right. If you see your name, let me see. I think I saw Dr. Hawkins. No, Dr. Honora, you're there. You're not raising your hand. You're not getting off the hook that easily. I've unmuted you. Are you ready for us?
I'm here.
Yeah, I didn't see a hand go up. I'm like, are you trying to go under the...
No, not really. I'm here to do anything.
All right. Tiffany, I see you raising your hand. I know we skipped your name, so I'll go back. All right, Tiffany? You'll be our last examiner. How does that sound? Good? Or you'll be our last person in the camp. So I'll take Stella, and then I'll take you, Tiffany. All right? Perfect. Let's go there. Okay, and then let's do this. And let's do this. Okay. A 26-year-old, right, presents to the office, I don't know, there's no gestational, there's no gravity parity, nobody cares, right, who presents to your office at 30 weeks of pregnancy. On exam, her fundal height is measuring 24. So what's your next step in management?
So I'm looking at size, date discrepancy. This might just be it's either she is fetal growth restriction, and could be poor dating.
Okay, so doctor, how are you going to manage this patient?
Okay, so the management, I will have to repeat, I'll do a sonogram in order to.
You did a sonogram, and the sonogram is consistent with 24 weeks.
Oh, okay, it's consistent with 24 weeks. Okay, so at 24 weeks, this is a patient that will, at this point, will need glucose challenge test at this age, and then also CBC will be done at this point as well. What else?
So, doctor, after you're reviewing this patient's history, it shows that she was dated by a last menstrual period corroborated by a 8-week ultrasound, which would indeed put her at 30 weeks.
Mm-hmm.
But the baby's measuring 24.
Oh, okay. So if that is
I'm going to stop you here, right?
okay.
See how I've taken you into a place that you're not going to be happy with now.
Oh, no problem.
Yes. So what do you think would be, let me now reset and imagine that we had not gone through this. And I'm going to ask you again and give you an opportunity to reword your answer. All right? So start all over, forget that we even did this.
Okay. So being that we have early sonogram.
And I'm gonna help you a little bit, right?
Yes.
Imagine you're in the office. Forget about the exam. And you measure the fundal height, and your fundal height does not match the last menstrual, it doesn't match what is listed in your chart. What is the first thing that comes to your mind? Forget about the exam. Forget about the exam at all. What's the first thing that comes to your mind?
So the first thing that will come to my mind is fetal growth restriction.
Or incorrect.
Okay.
So how are you going to tackle this? The first thing that comes to my mind is, how was this pregnancy dated?
Yes, that was why I said could be poor dating.
Right.
I said that earlier.
I know. I'm trying to make sure that but then you went to, I said it was 24 weeks. You said, okay, then I'm going to manage her as a 24-weeker, but you didn't say I went back and confirmed, right? So you've always got to be, in this exam, clear cut. The first thing that I'm going to do is I'm going to review this patient's chart, see what was the way that we got our dating, correct? And then if her dating was incorrectly labeled at 30 weeks, because I have an 8-week ultrasound that tells me she's 24, that is 7 weeks discrepant than her last menstrual period, I'm going to use her, right? Do you see where I'm going with this?
Yeah. Okay.
I'm just telling you, in this exam, you want to be elegant, right?
Okay.
All right, perfect. So let's assume that your dating criteria is correct. What is your next step in management? You said you want to get an ultrasound. Here is your ultrasound.
Okay, so let's see. Okay. All right, so I will cancel the patient that her baby is not growing as expected. And for that we will need to be monitoring her more closely. So this patient, from the clinic, I will send her to 11 delivery, where NST will be done, and then BPP will be repeated in 24 hours as well at a time. Meanwhile, MFM will be involved in the management of this patient, given that she has a severe fetal growth restriction.
So, doctor, give me some of the things that would make your baby fetal growth restricted.
Preeclampsia, or rather chronic hypertension, fetal growth restriction, what is in the setting of multi-fetal pregnancy, diabetes, advanced maternal age.
Non-medical things that would make your baby small.
Non-medical.
Baby related, fetal related.
Oh, okay. So aneuploidy, fetal anomalies.
What else?
Then placental chronic abruption.
Okay.
Vasa previa.
What if I told you there was also calcifications in the liver, calcifications in the head? What would that make you think?
Oh, okay. So we are also thinking of touch.
Okay.
Yeah, toxoplasmosis and CMV.
Okay. So you said that you would keep the baby
Mic off.
in 24 hours. Is that correct?
Yes.
Even if your NST was reactive, which would give you a BPP of 8 out of 10?
Oh, let me see. I don't see the NST on your.
No, I am telling you. If
okay. Oh, yeah. If NST is reactive, so 8 out of 10, we don't have to repeat in 24 hours.
Okay, I see. So, and unfortunately, MFM is not available for consult. What would be your management for this patient? What else would you like to, what other information would you like to know?
Okay, so SD ratio will be necessary in the fetal surveillance, and then also.
Is there anything else on the ultrasound that you would like me to add?
I said SD ratio.
Oh, I'm sorry, I did not hear that. So you want Dopplers?
Yes.
Okay, so let's assume that your Doppler comes back like this. What do you see here, and how would your management be in this situation?
This is absent end-diastolic flow.
Good.
So
let me remind you, you're now 35 weeks of pregnancy.
Oh, okay. So this patient would deliver her by 35 to 37 weeks.
You would keep somebody with absent reversal of flow pregnant till 37 weeks?
I know it's a range. It's a range less than 37 weeks, but by 36 weeks, she should be delivered.
Are you sure, doctor?
Yes.
Okay, how would that change if you have reversal of flow?
Huh?
How will that change if the flow is reversed?
For reverse, end-diastolic flow, delivery will be much earlier.
Okay, time.
Like 34 weeks.
Okay, time. So what do you think you could have done a little bit better on?
Initially, I recognized that this is a size date discrepancy, and I recognize that it is fetal growth restriction, probably, one of the differentials. And but I was going in that direction, but when you told me that it was dated at 8 weeks, so I'm like, okay, we have a definite early dating,
Right.
because
But
I also think that part of the problem might be dating.
Right. But remember what I'm trying to say, and it's up to you how you want to approach the exam. This is only a suggestion, right?
Okay.
It's not, everybody has their own way of how they want to approach the exam. This is only a suggestion.
Okay.
You want to be as clear cut with the examiners as possible, right? You don't even want them to be ambiguous.
Mhm.
You tell me what would have been a more clear cut answer. If you had said, before I do anything, I'm going to review the patient's chart
Mhm.
and see what was used to establish her due date and make sure that our due date that is used is correct,
Okay.
right? It's a suggestion. It's up to you, right? And then what is the next step in management? To me, it's always, I'm going to counsel the patient on the diagnosis, tell her what could potentially cause the diagnosis, and then I'm going to, in conjunction with my MFM colleagues, go ahead and put a management plan for you, right? What is that management plan going to be? It's going to include antenatal testing, serial growth ultrasounds, and Doppler studies. The
Mhm.
timing of delivery is going to change based on different scenarios, okay? Now, I would recommend that you review your delivery dates because they were not consistent with what ACOG would recommend. Okay?
Okay.
So if you look at ACOG, it says normal umbilical artery Dopplers and fetal growth restriction between the 3rd and the 10th percentile, deliver at 38 to 39 weeks. Less than the 3rd, you deliver at 37 weeks. Increased Doppler studies with no absence or reversal is 37. Absent is 33 to 34. Reversed is 32 to 33. Okay, and that is not me. This is ACOG in the medically indicated delivery.
Okay.
Okay, all
Yeah.
right. And I'm trying to give you feedback. I mean, take whatever you want from it, but this is the feedback that I see. And trust me, I've been doing this for a good number of years. I'm just giving you a suggestion of how I think that answer could have been better. Okay,
Thank you.
all right, take care. All right, Tiffany, you're ready? I'm gonna unmute you, Tiffany, right? Okay. I don't know why I unmuted you, Tiffany. Can you try speaking, see if I can hear you? Tiffany, are you there? Okay. I don't know what is happening, Tiffany. I can't hear you, Tiffany. All right.
Mic on.
Okay. Dr. Du, are you ready for us? Or do I see anybody else before Dr. Du? Angela, you ready?
Hello.
All right. You ready for a little bit of quizzing?
I am.
All right, let's go. So, a 25-year-old G1P0, okay, at 27 weeks presents for a prenatal visit, right? While talking to her, she informs you that several children, I don't know what wrong is this, several children in her school had red cheeks and mild upper respiratory symptoms. So the first thing is, what is your initial suspicion of a diagnosis?
So my concern when I hear this history is that she's been exposed to children with parvovirus.
I see. So if that's your concern, tell me how will you proceed with a case like this?
So first I will talk to the patient, see if she herself is experiencing any symptoms such as mild upper respiratory symptoms or a rash. I would also recommend that we do blood work on her, so antibody testing for parvovirus to see if she has previously been exposed in the past and has immunity to the virus.
Okay, so can you please walk me through that? So what specifically, you said what antibodies are you going to look for?
So I would look for the parvovirus IgG and IgM antibodies.
I see. Okay, so let's assume her IgG came back positive. What would you tell the patient and how would you counsel her in such a scenario?
So I would tell the patient that she already has antibodies against parvovirus, so must have been exposed or infected sometime in her past, and therefore she is immune to any future infection.
Okay, I see. So would you not do any further testing at that point in time?
Right. So at that point, I would inform her that that her fetus is not at risk, so I would not do any further testing.
See. So how would that change if your IgM was positive?
So if my IgM is positive, that indicates a more recent infection. So I would inform her that in this scenario, there are possible risks to the fetus, including a risk of fetal high drops as well as stillbirth. So I would recommend close monitoring of the fetus.
Can you be more specific? What close monitoring are you going to do?
So I would do weekly NCA Dopplers as well as ultrasounds to screen for fetal anemia and high drops.
I see. So you said you're going to do a what Doppler? I'm sorry.
Middle cerebral artery Dopplers.
I see. And for how many weeks are you going to do middle? So you said weekly till delivery, or for how long?
No, I would just do this monitoring for 8 weeks.
What made you choose 8 weeks?
So after 8 weeks, if we do not see any concern for fetal anemia or high drops, the risk that the fetus will develop any of those beyond 8 weeks is very low.
Okay. And when you do the peak systolic velocity, are you looking for a specific number that tells you that the baby may be anemic?
I would have to look this up again. The number that's coming to mind is 1.5, but I would double check before giving this patient any firm recommendations.
Okay. So let's assume that another scenario arose, and when you did the laboratory evaluation, she was IgG and IgM negative. How would you approach such a case?
So I would counsel the patient that because she has negative IgG antibodies, she is not immune to getting parvovirus. So I would still avoid contact with any children who might have an active infection and take precautions such as wearing a mask and washing her hands to avoid acquiring a new infection. I would also repeat her antibodies in 4 weeks. Because
let's assume now in 4 weeks when she comes back, she is now IgG positive. What are you going to do in that scenario?
And she's still IgM negative?
Correct.
So yeah, that's an interesting scenario because in her initial test, if she was IgG negative, usually IgM would become positive initially with an active infection, and then IgG suggests like more long-term immunity. So I would be concerned that one of the tests was inaccurate, and
why not that the IgG IgM that was negative now is IgG positive? Because you went through the IgM phase. It's just that you didn't test her when she was IgM positive. Wouldn't that be also a scenario that could be possible?
Yeah, that sounds reasonable
So
as well.
So what would you do to be on the cautious side?
So to be cautious, I would, so let's see, she's 27 weeks.
Okay, I see. So let's assume when you were doing the peak systolic velocities, you said the number was 1.5. Let's assume that her peak systolic velocity now was 1.7 MOMs, and she's at 27 weeks. What will you do in that scenario?
So I would manage these patients in conjunction with my maternal fetal medicine colleagues. I would give this patient antenatal corticosteroids for fetal lung maturity, and I would recommend that she undergo a cortocentesis to check for fetal anemia.
Okay, then let's assume that fetal anemia is confirmed. What would be your next step in management? And I understand you're managing this with maternal fetal medicine, so what would you anticipate maternal fetal medicine to do?
So I would anticipate that they would recommend a fetal transfusion.
Okay. Are there any specific prerequisites to what type of blood you give?
Yeah, I believe you have to cross-match it to the fetal blood type.
But you don't know the fetal blood type at this point in time. You may for future, but at this point in time, you don't know the baby's blood type.
So to determine the baby's blood type, you could, I would have to double check and see exactly how they do this, again, in preparation for this procedure, but
let's assume that you did not have an ability to do a peak systolic velocity. Would you be able to utilize bilirubin levels in the amniotic fluid to guide you about anemia?
I am not sure if that is the case. I would have to look that up.
Time. How did you think you did?
You definitely asked some tricky questions there.
I absolutely did. But did you get the basics right, is the question.
I hope so.
Yes, you did. Okay. Now, did you answer anything where you didn't know that would have gotten you into trouble? No, you were very, very clear in saying, I'm not 100% sure. I don't know, right? But let's say, what do I expect you to know here as a generalist, right? Because this is a general exam. Are you the one that's going to be faced with this scenario before MFM?
Yes.
Yes. So should you know what the initial workup is?
Yes.
What is the initial workup? You said IgG, IgM, right? Correct?
Right. Correct.
And you said if the IgG is positive, she's immune, and I'm going to reassure her. So that's correct, right? Now, IgM is positive. What did you tell me? He was infected. So
yes.
Then I'm worried about fetal sequela. What am I worried about? Fetal sequela, anemia, and subsequent hydrops. So what am I going to do? Monitor the baby. How long did you tell me you were going to monitor the baby? For anywhere between 8 to 12 weeks. You used the minimum. That is correct. Okay. Then after that, what are you going to monitor? Hydrops. I could have asked you what hydrops is. I chose to ask you, okay, peak systolic velocity. You said, I don't know 100%, but if I had to guess, it was 1.5. 1.5 was correct. Perfect. So then when I told you it was 1.5, what are you going to do? You said a chordocentesis to confirm, because this is a screening test, not a diagnostic test. So you've got to confirm that the baby's anemic. So you got that 100% right. Now, when your IgM and IgG are absolutely negative, they're negative all the way, and then they become positive when you confirm that they were negative, correct? That means you must have gone through the IgM period but missed it. So then you assume that they are positive, and then you count from the exposure how many weeks have gone, and then you complement it till you get to your 8-week cutoff. Does that make sense?
Okay, yes.
Okay. Can I fail you or fault you for that? Absolutely not. Okay. Would you have passed by just getting up to here? Yes. The remainder of the stuff is just basically to see how tense you would get and how whatever, because who manages it after this? Not you.
Yeah.
Okay. But this is fair game you, right? Because I'm not going to, maternal fetal medicine is not going to suddenly jump in when somebody says, I got exposed to school children, right? So this is all within the realms of the generalists. And I was clear to kind of go into. Now, however, if you want for completeness' sake, and that's the only thing that you didn't answer, which is fair, is you transfuse them what? You don't know the person's blood type, you always give them O negative, right?
Okay.
So CMV negative, irradiated leukocyte poor. And that's it. So how well you did? Extremely well, right? Because did you get what a generalist should get? 100%. Is this an easy question? No. Is it one that you handled yourself very impeccably? Yes. Do you feel better now?
A little bit. Yeah, thank you.
You did well, okay? But what I'm trying to say is the exam is going to test your limits. And unfortunately, it's one of those, the better you answer, the more difficult the questions are going to go. And if you ask people that have passed this exam, they will tell you it was not the most pleasant of experiences because the examiners keep pushing on, right? You should actually be more concerned when you go out and the exam is much, much easier.
Okay.
All right? Good,
Sounds
good.
good.
Any questions about this? Oh yeah, you can't do bilirubin levels. Why? Because this is not a hemolytic, it's a production problem. So there's no hemolysis, no bilirubin.
Okay.
All right?
Is
Again,
there...
not your level.
Okay. Was there, when you were asking me about checking the fetal blood type, is there a way that people do routinely do that, or do all fetuses get the O negative?
The initial blood transfusion is going to be O negative, but then you've drawn blood, we'll send a blood type, and then the next transfusion is going to be specific to the baby's blood type.
Okay.
Because you're not going to transfuse a baby just specifically based, you can get a baby's blood type from an NIPT, right?
Mm-hmm.
But it's not 100% accurate, and this is a transfusion.
Right.
So you don't want to risk giving the wrong blood. So what's the safest option? To start with O negative always, and then draw blood, because you're going to draw blood, right? So you're going to get a baby's blood type, and then the next time it can be matched to be given to the baby's blood type. So when in doubt, you can always go give O negative, right?
Mm-hmm. Okay, sounds good. Thank you.
Did you find that this was beneficial and helpful for you?
I did, yes, very helpful. Thank you.
Okay. Did you find the other scenarios were beneficial and helpful?
Yes, they all were.
Okay, but see how we took some of them that were very basic, right? And dissected it and made sure that you guys knew the basic, and then we took some that are a little bit more challenging, right? Not all cases in the exam are going to be simple, right? But there's going to be enough simple cases for you to demonstrate your ability to navigate through general obstetrics and gynecology to pass. All right? Good luck. Well done.
Thank you.
All right, bye. All right, everybody, I hope you benefited from today's webinar, right? As usual, good luck on your exam. We're all available here if you guys have any questions, all right? Take care. I'll see you guys soon.